All righty. This is Dr. Russell Brown, and I'm here with uh, my first in a case review series. We'll be doing these once a month, and this is just part of what the supervision or collaboration guidelines require, at least in Georgia, that we provide some type of pharmacological training. So this is my effort to meet that requirement, and just want to let everybody know that we this is not the gospel according to Russell Brown. We have two textbooks that we use. One is called the Psychiatric Case Studies for Advanced Practice. The authors are Kathleen M. Prendergast and Casey Jackman. And the other text is Case Files Psychiatry, the sixth edition, and the authors are Toy and Clayman, Clamen. And today we're going to be discussing uh, uh, manic disorder or the manic phase of bipolar with psychotic features. And we'll go ahead and dive into the case. We have the identification. We have a patient here. He's a 29-year-old single unemployed Hispanic male who's just been admitted to a voluntary inpatient psychiatric unit. So he came in under his own will. His chief complaint when he got there was, "I was just trying to find the truth so I can save the world." Uh, History of present illness. Prior to being admitted to the inpatient psych unit, he was taken to the ER by the police. The police were called when he was observed wandering for hours in a parking lot. Approximately 1 month prior to his admission, he had been fired from a job he only had held for like 3 weeks for inappropriate behavior. According to his mom, the police had to be called in to escort him from the park because he refused to leave. Since that time, the patient has been barely sleeping, and the family heard him laughing and talking to himself at night. The patient said that his appetite has been non existent for the past 2 to 3 weeks. The mother said that although the patient is usually frugal, in the most recently, he had been spending excessive amounts of money buying expensive business suits, which he was charging to a credit card because he has no source of income since he lost the job. The patient said he is working on some creative projects that will save the world, but he's not at liberty to talk about any of them. He's religiously preoccupied and speaks of his special relationship with God. Um, he is sexually preoccupied, and he had been making sexually inappropriate comments to the female nurses while he was in the emergency department. As far as his past psychiatric history, the patient had no previous hospitalizations and had never been prescribed any psych meds. The only outpatient treatment he had was some counseling the previous spring at the university he had been attending. He said he did not find the counseling helpful. Even in his current mental state, the patient does have some insight into what was occurring and said he thought he had bipolar disorder. He reports that for the past 4 years, he has been having episodes which could be described as hypomanic a couple of times a year in the spring and then in the fall, increasing in intensity to the point that he failed his graduate program last spring. He said he also had some periods of extreme depression when he was not able to get out of bed. The family said that because the patient had been living away from home, they had not been aware of these problems until this current episode, uh, in which they are trying to get him some to seek some help. As far as his medical history, the patient has no known drug allergies. He does not have any current medical issues, but in 2008, he had a bleeding stomach ulcer that required 3 to 4 days of hospitalization, and he had a resultant 3 blood transfusions. He's currently in good physical health, normal height and weight. He has stable vital signs. The labs on admission included a CBC, comprehensive metabolic panel, thyroid stimulating hormone, and thyroxine levels, which are all normal limits. So he had the standard labs. Uh, as far as his drug or alcohol use, the patient says he began drinking alcohol and smoking marijuana at the age of 17. He considers himself a binge user of both substances. He says months will go by without him smoking marijuana, and then he will have a period of incessant use. He also said the same thing of his drinking, and he has experienced blackouts during his alcohol use. The most recent episode was period of binge drinking about a month prior to his hospitalization. Um, However, his blood alcohol level, and his urine drug screen are both negative on admission. The family history: the patient's older brother and paternal aunt both have bipolar disorder, so he does have a family history. His brother's illness is well managed. His brother lives independently and has completed his education and is gainfully employed as a professional. His maternal cousin has a history of schizophrenia. The patient was raised in a family where the parents have an intact marriage and they both are employed and are financially secure, so they seem to be doing all right mentally. The sister, the patient is the second oldest of four children. He has an older brother, a younger sister, and a younger brother. He's currently living with his parents and younger siblings. He describes himself as being close to his mother, but having a more contentious relationship with his dad, and he does get along well with his siblings. As far as his
Dr. Brown,
personal,
somebody's in the waiting room.
all right, get in there. All righty. Let's see who we added. Huh? All right. We'll get back to the
Okay.
case study. All right. Now we're at the personal history now, and his perinatal history is not known. Um, he had no identified problems during his childhood. He did well in school. Um, Adolescence, he did well academically in high school. In adulthood, after college, he was accepted into a master's program, which he struggled until dropping out this past spring, at which time he returned home to live with his family. So he was able to get through college, but started having issues after college. During the first year of his master's program, the patient was arrested for trespassing and resisting arrest. Uh, he gets see who else is in here. All righty, just adding someone else to the meeting. All righty. Um, Back to the case study. He said he was intoxicated with alcohol at the time of his arrest during the master's program, um, and um, and that the charges were dropped. Initially, after returning home, the patient was able to function in a job as a sports coach to some adolescents. However, he left that job to take on the one that he was just fired from. Trauma and abuse history. The patient denies any history of any trauma or abuse, saying that he had a wonderful childhood. So let's move on to the examination mental status. The appearance Uh, the appearance, the patient appears his stated age. He is impeccably groomed, wearing a business suit. He is cooperative with the interview and makes appropriate eye contacts. Um, as far as his behavior, he's very energetic and animated. He's alert. He's oriented to time, place, and person. His memory is not formally tested, but he is able to recall events in his life, given the exact. He's able to give exact dates from significant events in his life. Concentration and attention. The patient is easily distracted by things in the environment. For example, in the middle of a sentence, he was distracted by a small detail in a painting in the room, and he spoke about it at great length and needed to be frequently redirected to get back at the topic at hand. Abstract thought. The patient's responses indicate that he is able to understand general, specific concepts as well as generalizations. His intellectual functioning is he has above average intelligence, and this is evidenced by his vocabulary and his fund of knowledge. Uh, his speech is spontaneous, yet overproductive and somewhat pressured. The patient denies any hallucinations and did not appear to be experiencing any perceptual distortions or internal stimuli. Um, his thought processes were tangential and he had some flight of ideas. Um, as far as thought content, he displayed grandiosity. Um, he had religious and sexual preoccupation, and he had some mild paranoia. He complained of having some intrusive thoughts about other people and fearing that they could read his mind and know what he was thinking. For suicidality or homicidality, the patient he declined any suicidal plan or intent, but he sometimes wants to end it all. His family says that he has threatened suicide when intoxicated, but he has never made an attempt or a gesture. He denies any homicidal ideation, but says he often gets very angry with people. Um, the family says he becomes quite angry when intoxicated, but denies that he has ever become physically aggressive. His mood is elevated and expansive. His affect is over animated and congruent with his elevated mood. His impulse control is impaired, as evidenced by excessive spending and the inappropriate sexual comments. Judgment, insight, reliability. Although the patient has impaired judgment, he does have some insight into his condition, um, as he feels that he has an illness and needs medication and treatment to manage it. So we completed that. Now we move on to treatment planning and well, diagnosis and treatment planning. So, what diagnosis should be considered here? We have two of them. We got bipolar 1 disorder with mood congruent psychotic features, and the current episode rises to the level of mania. So that's why it's a bipolar 1. um, and we also have a secondary diagnosis of alcohol use disorder, which is moderate. So, for the diagnosis of bipolar 1, it is necessary to meet the following criteria for a manic episode. And the manic episode may have been preceded by or followed by a hypomanic or a major depressive episode. So, in order to have bipolar 1, you have to have just one manic episode um, associated with either hypomanic or major depressive episodes. Um, the rationale for this diagnosis is uh, for a diagnosis of bipolar manic with psychotic features is because there's a distinct period of abnormally elevated mood and it's lasting just 1 week and it required a hospitalization. During this period, there was some grandiosity. He had flight of ideas. He had pressured speech that we noted on the exam. He also had some psychotic features, thinking that people could read his mind. The episode is not attributable to a substance or any other medical condition. His medical history was clear, and his urine drug screen was negative upon admission to the unit. Uh, the patient's current presentation, uh, the family history, as well as the patient's report of his cyclical moods over the past few years, support this diagnosis of bipolar disorder. Um, does everyone agree or have any issue with the diagnosis based upon the history and the examination?
No.
Yeah, he's kind of textbook bipolar disorder, manic with a psychosis. Um, what tools or tests should be considered to help identify the correct diagnosis? Blood alcohol levels and urine drug screen. Um, if there's evidence of if there's evidence of recent alcohol or cannabis use, a diagnosis of substance induced mood or psychotic disorders would have been considered. And this is always, a challenge. A lot of people have dual diagnosis and they come in with positive screen or serum level and psychiatric symptoms. And the issue is, are these symptoms uh, primarily related to the underlying psychiatric disorder or related to the substance? And then the issue is, should I treat them or not? Classically, we're supposed to not treat them with anything but allow them to detox. And generally, it's about 30 days. But in this day and time, that may be a little bit um, um, inconvenient and unreasonable. Um, what do you do in those situations, Gilda? Do you do you have the luxury of waiting, or do you just go ahead decide to start something to start
Yeah.
treating the condition?
Yes. I don't have the luxury of waiting.
All
Uh,
right. Yeah. So you're
Yeah.
just waiting. You wait until they come back. Well, I guess if you're in an inpatient unit, you can wait. In an outpatient setting, what would you do? In an
Now,
outpatient setting, you may not even have access to the drug screen. But if you did, or if the patient admitted to it, what would you? How would you proceed?
so that's another thing. If they admitted to being intoxicated at that very time, then I mean, then it would stand to reason. Okay, maybe we should wait before
Hmm.
we treat and have
Right.
them come back sooner than later.
Right. Because you don't want them to escalate to the point where they would need to be hospitalized if you could treat them outpatient. But that's
Mhm.
always a tricky situation. And in some instances, I go ahead and I may start something, but and it's according to what the substance is. But people are never honest. So
Some of
um,
them are,
so
but what if it's a whole lot of marijuana?
yeah,
Because
exactly. If it's marijuana, I'll go ahead and start them on a mood stabilizer or antipsychotic. Um, but just tell them, you're fighting the effect of the drug, you know. So you need to just you need to you need to chill out. So
what some people do and what some people don't after you tell them they have to chill out from.
I
Because
know,
that's the only thing that helps me.
right, right, exactly. That's my. If I stop taking it, I won't. The situation will get worse until it gets better. So it's a quandary, but we don't have the luxury of putting people in hospitals and for 2 weeks or a week to to let them dry out before we can start treatment. So you just got to play that one by ear, and
Mhm.
hopefully they got good family support um, around them. So Let me see.
So, hi, my name is Oyeronke.
Hello.
It's my first time here.
Hey,
And hi. So, for me, in an outpatient setting, I think I would start him on an antipsychotic for like 5 to 7 days and have him come back and maybe call a family member just so they watch and make sure he's okay. Um,
mhm.
because, like you said, we don't have the luxury of admitting him just to make sure that he's all right. I think I'll treat him.
You
Short
think you
course.
treat them? Yeah. More likely than not, I'd go ahead and treat them too if they had something positive. Marijuana or alcohol, I'm not gonna worry. But if it were methamphetamine or cocaine, um, I would I probably would just have them come back in a couple of days. I wouldn't even give them a week off
Right.
and let that stuff get out of them and test them again. Because if they're manic and psychotic, but they're using cocaine or an amphetamine, I mean, there's really no use in treating them. They got to get off the. I mean, you know, the chances are it's probably the amphetamine or the cocaine that's actually creating the behavior or really
Mhm.
aggravating it, and giving and treating them is just not going to do any good. So you just got to play that one by ear and make a decision, based upon what you think they're using, and then also based upon their family support. Does anybody else out there have any thoughts or ideas that's on the call?
Hello, my name is Latoya. I came in a little late, so are these patients do they already have a known psychiatric history, or are we trying to figure out if they're having a psychotic break opposed to being drug induced?
This is a
So
this is a case of a guy with bipolar mania with psychotic features.
okay,
His drug screen actually is negative,
okay,
but one of the things we need to consider in this diagnosis is substance use, and we're just extrapolating, saying, well, what if his drug screen was positive?
hmm
What would you do? Would you wait for him to detox, or would you go ahead and start your treatment for the acute psychosis and mania
okay.
now?
Yeah, for
And
me, it would probably be like you said, talk to the family and get a little bit more history as to if he was manic before he started using or went on his binge. So then
hmm
that will let me know if he was already in a psychiatric state before he started using. Because sometimes I've met patients that start using because they are in a psychiatric state. They don't want to hear the voice. They don't want to see
right,
the hallucinations. So they'll go and they'll start using substances.
right,
So if that's the case, then yes, I will absolutely treat, especially if they were already having the symptoms prior
yeah.
to taking the drug.
And once again, once you treat the psychiatric symptoms, sometimes the substance abuse problems will go away, because they're self-medicating, and you're not really dealing with a primary substance use disorder. So, like I said, you just got to get more facts, more information, more history, and then make your decision based upon that. So let's go ahead into the secondary diagnosis. This is this would be alcohol use disorder, moderate. And question is, what is your rationale for this diagnosis? The patient meets the criteria of at least 4 to 5 symptoms of alcohol use disorder, moderate, because one, he has a problematic pattern of alcohol use leading to clinically significant impairment, evidenced by consuming larger and larger amounts than intended, and that's the incessant use of alcohol. Um, Two, he has continued use despite having persistent problems caused by the effects of drinking alcohol. He has hazard issues, which includes the blackouts, um, and all and what and as far as number two, the persistent problems. He gets drunk and he ends up trespassing, gets arrested. So the alcohol creates some unintended consequences, and then he has the physical symptoms of the blackouts. And his alcohol use is continued regardless of the knowledge of the physical or psychological problems that could occur. Um, he describes the sporadic episodes of binge drinking since the age of 17, and then he has all these attendant problems, getting arrested, trespassing, becoming violent, you know, becoming a little aggressive at home with the family, and he just continues to do that despite some of these psychosocial issues. Um, so we get to the point of which additional diagnosis could be considered, and here we have cannabis use disorders. Although the patient reports a history of cannabis use since the age of 17, in a binge type pattern, not enough information was available to identify a problematic pattern of use leading to a clinically significant impairment or distress. However, the patient or his family may provide additional information that would indicate that he does meet the criteria for cannabis use disorder. So, the point here, take home point here, is just you got to get more information. Sometimes you got to get on the phone, call mom, dad, sister, brother, cousin, or someone that knows the patient in order to make an accurate diagnosis and put together uh, a decent, relevant treatment plan. So, speaking about treatment plans, let's talk about formulating a treatment strategy. So, what treatment would you prescribe, and what is the rationale? And we'll start first with psychopharmacology. The author here suggests valproic acid or Depakote ER 1,000 milligrams a day. The first goal of treatment is to control the manic and psychotic symptoms with psychopharmacology because the patient understood that he had bipolar, so he has a little insight and needed treatment. Options for medications were reviewed with him within the constraints of the hospital formulary because he's currently inpatient. He was given a choice between lithium and valproic acid as a mood stabilizer, and he chose valproic acid, which I don't blame him. Yeah, lithium is from the dark ages. It's a good medicine, but it's a little harsh. Um, Current evidence recommends a combination of lithium or valproic acid with an antipsychotic for severe cases of mania. So what do y'all think about that? What do y'all think about those two options as initial therapy in this case? Agree, don't agree, other
I'm
options?
I'm I'm not the biggest fan of Depakote simply because I feel like there's so many new and improved types of medications, but like you said, within the constraints of being in an inpatient setting, you don't really have the option for the more newer types of medications. But I mean, is this I didn't hear the whole thing. So medically, is he healthy? Like labs were done, no labs were done to determine like is his liver fine? Can we really put him on Depakote?
Yeah, they did a liver function test, thyroid, TSH,
Mm,
thyroxine, CBC, and everything was fine.
okay.
His
Okay.
labs were looking good, and he was not on alcohol when he came in. So I mean, and his drinking is binge drinking, and it's not continuous. So he did have, in his history, I mean, but this is just related to the alcohol. He did have a
Mm,
history of a GI bleed um,
mm,
way back when, but that may be related to alcohol, and he
oh,
had to have three blood transfusions. But overall, his liver function tests were fine. So
okay.
what? Well, so if you had an open formulary, what would you choose?
I like Graylar to be honest.
You
I would go more for something like Graylar. It's usually one of those medications that I've seen have been very beneficial and quickly too.
know? And you feel
And
that's
it
better
can
with.
treat.
Hmm. Go ahead.
Not that I guess in terms of if you're looking at side effect profile, um, Depakote, to me, yes, you need for bipolar, you need mood stabilization, but he has psychotic symptoms too. So I feel like for me, I would go, if I had an option open, I would go for something like Vraylar versus going for Depakote, unless I did not have a choice.
Yeah, you want to get two birds with one stone.
Yes.
All right.
But that could be hard when they have insurance issues. Even in the outpatient setting where they're always asking for, for you to use something like Depakote, or they're not about to just hand out Vraylar. And some of the patients, especially in underserved populations, they can't get that drug.
Right. I found some workaround with that, like connecting with the drug reps, where if you're using, as long as if they don't have commercial insurance, okay, that's a whole nother thing. But if they have commercial insurance, in that case, like I'm just thinking about one thing, there's a slew of things that you have to think about in an inpatient setting. But I found a workaround with that where there's a specific way that you got to explain it to the pharmacy when they're running the prescription. It has to be ran with the insurance. Once the insurance denies it, the manufacturer will cover the medication. But you have to enter the coupon and with the insurance. If you do it separately, it won't work. So I've used it and found that I have been able to get people to get the medication using that method versus just sending it to the pharmacy like that. It obviously it won't get approved by itself.
All right. All right. But based upon this text, so they wanted to do a process where they hit one symptom with one drug. So they got the Depakote for the mania, and then the book, the author here represents uh, then states recommends risperidone 2 milligrams BID for the psychotic symptoms, and then they recommend trazodone 100 milligrams at night for the insomnia. So, where you could probably do a 1 for 3, 1 for 2, or a 1 for 3. They
Even
they split it
Seroquel.
up. Yeah, yeah, and Seroquel could be good too because you could get both sleep and the psychotic symptoms.
Yeah.
Yep. Yeah.
And could stabilize their mood as well. So I don't like polypharmacy, like mixing a bunch of stuff together. So if I can avoid doing that, knowing that this one agent can treat multiple things, I would go for that versus like, treating symptoms versus treating the diagnosis. I prefer to treat the diagnosis as one, then, one thing for this, one thing for that, one thing for that. And the next thing you know, you end up with so many medications.
Let me ask you all this question. Would you, if this patient came to you as an outpatient, would y'all treat him as an outpatient, or would you recommend that he be hospitalized for treatment? This particular guy here, I mean, he's having some problems, and he was, but let's say the police didn't come, his family just brought him to your clinic. Would you be comfortable treating this guy as an outpatient with whatever medication regimen, and let's say he happened to have a drug screen and you knew he wasn't using anything? What would
Yeah, I would
y'all do?
probably recommend him be hospitalized for safety and to get stabilized because I, I don't know his history of taking medication, being compliant, and if he's already this manic and he's been this manic for, you said, for a week, I think. How many days had he been manic before?
It looks like he's been manic. Yes, he's had 3 weeks of inappropriate behavior.
Yeah, he needs to be stabilized. So I would probably recommend that because if it's 3 weeks, I don't know what his compliance status is with his medication, how he takes it, if he has a support to make sure he's taking it. So I will probably get him stabilized to where he can be on, I guess, even kill when he comes out, and then his support and get him set up to where if he is going to get injections or if he's going to get medication, pills or
Mhm.
whatever to make sure that he's continuing with the medication.
So he's gonna go to the CSU, huh? Get a little vacation, a little staycation. All right. All right. Let's look at some diagnostic tests based upon the three meds that this author used. So, laboratory tests to monitor valproic acid levels and to identify hepatotoxicity or pancreatitis are essential. Therapeutic drug levels for the Depakote is 550 to 100 micrograms per cc. Initial lab should include liver function tests, CBC with differential, coagulation tests, they say here hereditary mitochondrial disease may predispose to hepatic complications. So you may want to get a history if they have any mitochondrial diseases like MERF or MELAS. Those are the ones I know from being a neurologist, but I'm sure there are other ones because they complicate the metabolism of the Depakote. But even with that, if you don't know it, always check a level. If the patient is a female, a pregnancy test is indicated because valproic acid has the potential for uh, terato- yeah, teratogenic side effects. AIMS evaluation for movement disorders. The patient should be evaluated for medication-induced movement disorders that may be caused by the risperidone. Neuroleptic-induced movement disorders include neuroleptic-induced Parkinsonism, acute dystonia, akathisia, and tardive dyskinesia. In this case, you just want to get a baseline and have that documented. Neuroleptic malignant syndrome is another potential complication with neuroleptics. Now, the question here is, does NMS, can that occur with the first dose, or is that a cumulative? Is that diagnosis based upon the cumulative amount of neuroleptic, or can it just happen with the first dose?
It could just happen with the
Could
first
just
two.
happen.
Yeah, yeah. When y'all do y'all's um, um, consent with the patient, do y'all often discuss this if y'all putting people on
Well, I
antipsychotics?
always I always go over if they're talking about education, risk, and benefits of medication. I mean, I feel like that's one I always write in a note now, discuss NMS and what it looks like so that they're aware. And if
Mm-hmm,
their family is there, what to look for.
mm-hmm.
If it happens and say, this is a 911, this is not a wait, this is a go to the ER,
Yeah, yeah,
stuff
yeah.
like
You
that.
can't. Yeah, that's not an overnight. Well, I'll just go see the doctor tomorrow.
Right.
Yeah, you got to. Yeah. Symptoms include muscular rigidity, dystonia, akinesia, mutism, obtundation, agitation, along with fever, sweating, elevated blood pressure, and pulse. So it's life threatening and will require intensive care treatment. So, yeah, that's something to definitely let your folk know about. It doesn't happen very often, but when it does happen, action needs to be taken. Laboratory findings in NMS include elevated WBC, elevated CPK, elevated liver function tests. There's myoglobulin in the plasma as well as in the urine. Uh, uh, as far as referrals, referral options may be limited by the type of insurance. The patient should be referred to a hospital affiliated or a community based outpatient program that would provide them with medication monitoring, cognitive behavioral group therapy, including groups that addresses substance use as well as individual counseling. So that could be a partial hospitalization program as one, if one is available, or an IOP program, community-based IOP. His family should be referred to an intensive family support service in order to help them better understand the patient's illness and the need to monitor his treatment. Type of psychotherapy, once again, cognitive behavioral group therapy, substance abuse therapy, and individual counseling, as well as family counseling for the family. Psychoeducation, there are many different tools. There's a Depression and Bipolar Support Alliance. and that's a national organization that provides support and education for patients and their families affected by bipolar disorder. And local chapters can be accessed at www.dbsalliance.org. As far as the medication, um, you can go to NAMI, and NAMI has information on the Depakote as well as the risperidone. Do y'all have patient handouts for medications as well as diagnosis to give, or do you just send people to a
No,
website? Or?
I have it where you can actually attach it as a patient education into their portal.
Mhm. But do you have something where they
So
can
you
take
can send.
home? Do you
No.
have? Yeah, yeah. Some of the clinics that where I'm at, I'm asking the clinic to have some stuff either already printed out, the top 12 diagnoses, or just based upon what it is, have somebody just shoot out something about the meds and something about the diagnosis. And sometimes that's more for the benefit of the caregiver than even the patient, so they'll kind of know so if something happens, they can kind of talk to intelligently to another provider if there's an acute situation, and you're not available. Um, what standard guidelines would you use to treat or access, uh, treat or assess this patient? There's several different guidelines. The APA has a bunch of them. This book recommends the clinical management of bipolar disorder, a review of evidence-based guidelines, and it's from NIH. So, but NIH has them, APA has them. Um, of clinical note, if the patient tolerates a starting dose of valproic acid, 1,000 milligrams daily for at least 3 days, and his blood levels is within the lower range of 50 to 100, the dose can be increased to 1,500 daily. So you can do a quick bump up. Um, The valproic acid level should be checked after any increases in the medication, and particularly before discharge to make sure it is within a safe range. Um, Additionally, his risperidone dose may need to be adjusted depending on the degree of remission of his psychotic thinking or the development of any side effects. So let me ask you this. The cause of his condition is the mania. Once you take care of the mania, what do you think happens to the psychosis?
Probably could go away.
Yeah, it should go away. It should go away. Now, let's say if his psychosis didn't go away, what could it be? What could we possibly be dealing with? What's another alternative diagnosis?
I'm thinking like maybe schizophrenia or something.
Schizoaffective disorder.
Mhm.
Yeah. And what's the difference between schizoaffective disorder and bipolar mania with psychosis?
Schizophrenia with a mood disorder. Schizophrenia symptoms or psychosis with a mood disorder happening.
All right. Well, the official thing is, uh, as opposed to schizophrenia and bipolar disorder with psychotic symptoms, schizoaffective disorder patients must meet a criteria for a major mood episode for a majority of the illness and have delusions or hallucinations for 2 or more weeks in the absence of a major mood episode. So that means that in bipolar disorder, uh, mania with psychosis, they occur together.
Mhm.
If the person has psychotic symptoms, um, 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 apart from being manic, that's schizoaffective disorder. If they occur together all the time and they never have an independent um, psychotic episode, then it's schizoaffective I mean, then it's bipolar. If they occur together, it's bipolar. If they have separate times where where they have a mood problem and a psychosis, and but if the mood disorder goes away and they're still psychotic, then more likely they're schizoaffective. Does everybody get that?
Yes.
Mm-hmm.
Yes.
Yeah. Um, and those two disorders, they're treated the same, but there's some nuances in the differences in their treatment. And we'll do a case review on schizoaffective. I probably may do that one next.
Mhm.
Yeah, essentially over the lifetime of the illness, the patient must present with just psychotic symptoms and no mood symptoms for at least some of the disorder, but at other times, both mood and and the psychotic component can run concurrently, and that's an schizoaffective. Um, uh, Another clinical note, there's a possibility that the patient may have less binge substance use episodes if the mood is stabilized. However, if the substance use continues to be comorbid, it should be addressed concurrently. So once again, it's the same thing. If you treat the mania, the bipolar, hopefully the drinking will go away. I think in the case with this guy, his drinking predated, or his problem drinking predated his diagnosis of bipolar, and he probably is comorbid. He has two separate diagnoses: the substance use disorder as well as the bipolar. One is not dependent upon the other. Um, Other clinical note: other patients taking Depakote, among patients taking Depakote, there is an increased risk of hepatotoxicity, especially in the presence of these mitochondrial disorders. So, if someone has some really weird, funky neurological problems, um, they may be the result of one of these mitochondrial diseases. Normally, things like MELAS and MRF, we don't need to get too deep into them, but they have, and they're encephalopathic, they got myopathies and a bunch of other weird things. You just want to be very ginger with dosing the Depakote because they may not be able to metabolize it as well as a person without these um, concurrent illnesses. So, are there any questions or uh, other opinions about this case and how it was treated and how it was managed, diagnosed? Does anyone have any similar cases that they would like to present, get some feedback on?
I feel like I have a teenager, not in the drinking or smoking, no substance use issues, but she's really hard to figure out. She's still very, very she just may have schizoaffective disorder. None of the antipsychotics work for her, really.
Hmm.
She
Hmm.
said she feels a little bit better on your antiquated lithium,
Hmm.
which she she feels a little bit better on that, but still having some audio visual hallucinations that can't seem to get rid of, even with lithium and antipsychotics and all the things I've thrown at her for at least a year now.
Hmm.
It's so hard to figure her out because one minute she'll come and she say, well, I think I'm feeling better. The hallucinations, have subsided some.
Hmm.
Then the next visit,
Hmm.
they're there. She can't sleep. She's got crawling bugs everywhere, you know.
And she'll be having these variations in symptomatology on a stable regimen, right? The regimen is not
Yes.
changing, but her symptoms are changing.
Yes.
Mm.
Because at one point I said, oh, maybe it is bipolar. And she's just doing all these weird things. And she was admitted to the hospital at one point sometime last year, but
Hmm.
then got out and said she was doing fine. But now we're still seeing things.
Hmm.
Can't sleep.
And she's not on any illicit substances. She's pretty clean.
Pretty clean.
Hmm. Adolescent, you said?
Yeah, she just turned 18. Yeah.
Hmm.
At that time, do you now begin to consider, is there anything medically going on that could be causing, these like tactile hallucinations that she's having,
So
like is
she's
there like
not feeling them, she's just seeing them.
seeing them? Okay, I thought that she
Yeah.
was feeling them on her
No.
skin.
Yeah, no, she's just seeing them.
Is she, what medicine is she on? I don't, I
Right
think I missed that.
right now right now she weaned herself off of the antipsychotics no matter what I put her on. She weaned herself off. She's just on the lithium that she says she feels a little bit calmer on, and citalopram. That's the only two things she's willing to take, even though she's still seeing these things, because she said she still saw them on the
Mm-hmm.
antipsychotics, but she felt she was developing a movement disorder and she wanted to make sure she was not developing tardive dyskinesia. So she weaned herself off of all the antipsychotics.
Does she have borderline, maybe?
Does she have any emotional?
Mhm.
I just know
Are these symptoms? Is there an emotional
there's a whole
component to it?
family history of it, all of her siblings.
Borderline
Hmm.
personality disorder or bipolar?
Bipolar, every mood disorder, everything you could
Oh.
think of, all of the siblings. And it's like four of them, they were all adopted and they've
Mm.
all had the same problems.
Mm. Does she have a history of
She needs to
trauma?
see.
Well, trauma, yeah, they've been adopted. I think they grew up, I mean, they were in a home
Mm-hmm.
um, that had significant trauma while they were all removed.
Has she done like a DBT kind of therapy?
I don't, it was at the place where I left Dr. Brown where they
Okay.
didn't do too
Okay.
much therapy.
Okay.
Yeah.
Um,
So
so,
she may benefit from that.
uh-huh.
Yeah, yeah, yeah. When things are unexplainable and they vary on the same regimen. And how long was when you put her on an antipsychotic? I mean, did she even take it at all, or did
I
she even
believe she
give it?
took it because her mother is very involved and is usually on every call. And she goes through the medication bottles and she's saying, if she's out of medicines and she's making sure she gives her the medication.
Mm.
So I feel like there was medication compliance. And the mother was
Do you
actually journaling some of the things to, like, oh, she would come to the room at night because she can't sleep, say she's seeing things, hearing voices. And then she would say sometimes she had a great month.
Mm.
Then other months, not so great.
And
That's
that's what's
very
like,
odd because like psychotic symptoms that come and go.
No,
yeah.
to varying degrees though. Like it would be really bad one
Mhm.
month, and then another month you'd be like, oh, it's still there, but not as bad as it was last month.
I wonder what is changing in between the time. Is it like something major, like a psychological stressor? Is something major happening between the times that she's having a great month versus not having a great
Good
month? Like,
month.
are there any particular things happening in the environment?
No, that I don't think I can't say I remember her saying
That's because I
anything.
always assess for like stress, because some people will have worsening of symptoms when they are stressed out. Like, is it, or like, are you creating these things or are you actually seeing something? Because sometimes too, a lot of things can also be in your head, which is difficult to tell a person like it's in your head. But when she describes it to you, she said the stuff's crawling. What else is she saying that she sees?
Other than animals and faces and black shadows in a corner.
Mm.
Yeah, there's usually a lot of animals, insects, and tall black shadows, things like that.
Yeah,
Maybe it may also be trauma. All of those things.
yeah. Yeah. It sounds like this is trauma related events, and her, even her subjectively. talking about them. A lot of times, psychotic people, they're not as objective about what happens to them. You know, they're not as reflective about it. She seems very reflective about her breaks with reality. So you wonder if they're really true. You know,
Exactly what I'm thinking too.
Because
yeah,
I feel like I ran her by you a long time ago when we
yeah,
had her on a couple of antipsychotics, and it was
yeah,
like, okay, if if this is real, we're hitting this dopamine pathway really
and
hard, and this should help.
right, yeah. And psychosis, I mean, if you have one of these brief reactive psychosis that's stress related, it kind of varies and comes and goes. But she's
Mhm.
been having this for how long?
I have seen her for more than a year now.
Yeah, it 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 doesn't sound like a typical schizophrenic or schizoaffective type of situation. So, you know, it sounds like it may be more stress related, like the brief reactives, you know, the a brief psychotic episodes that people have. And you said that she never had that one hit of acid or bad marijuana. She doesn't report anything like that.
No,
That
never.
yeah, yeah. Then it's probably some kind of stress. She's in therapy?
Well, I will see her again tomorrow. I
Mm-hmm.
don't know if they were able to get her in good, consistent therapy,
Mm-hmm.
because that's always my big push for people. But I don't know, and I'll check again tomorrow to see if if they were able to get her in good, consistent therapy. Her mother
Yeah.
was even thinking about ECT and TMS, and
Yeah.
she's trying to do all those other other things.
Yeah. I would probably just even talking to somebody and then you can track if these symptoms get a little better and with less variation.
Hmm.
Because that's kind of strange, and there almost seems like there's some kind of periodicity with it, you know, which I don't think true psychosis really works like that.
Right.
Doesn't.
Yeah,
Okay. Well,
yeah,
I'll check on her tomorrow.
yeah, yeah. Just give me a call and we'll see. But
Yeah.
she's not on any antipsychotic right now, though, right?
Nope. None.
Mm, yeah,
Because I even thought Seroquel would be great and do like what I think is Sable was saying, just it could help her sleep, it could manage this because
hmm
she's having issues with us. And no, she
What's the
she,
longest she take her
she
medicines? Like when you prescribe them, how long does she take them before she weans herself off?
oh, she was on antipsychotics for months. I
Okay.
mean, a good stretch.
Okay.
But
mm.
then she started to feel like she was having tardive dyskinesia symptoms with these jerky movements, and she said, "Well, I don't want that."
Did you did you ever witness any of those movements?
Never, never, never.
Like
Yeah.
it's so complicated, man. Oh my
But when I tell them all the time, I said I could
God.
tell you and I could prescribe all day long, but it's what is what you do with the medicine after.
And
Yeah.
then sometimes they feed off of each other, especially if she has siblings who have the same things. They
Hmm.
Google all this stuff, right? They know all of these things. And then
Very
they feed off
complicated.
of on I used to work at a group home and they always said the same thing. And I'm like, there is no way. Everyone is, you know.
Yep.
So yeah, they feed off from each other. I do know that for sure.
Yep.
So,
I have what she has, you know.
Uh-huh.
Dr. Brown, I don't know if I feel like this would be a good thing for everybody to hear. Do you remember that patient? Maybe I never actually I think I did. So, 40 something year old female, she started to experience a stressor induced illness after her grandmother passed away. She was in college. She was in some Ivy League college and she was in this really elite program. I don't remember exactly what it was, but she was really excited. She was there. She was really happy. And then her grandmother passed away and then she went mute. She wouldn't move. She stopped talking.
Hmm.
She everything just basically switched off after this happened.
Mm-hmm.
So they had to get her hospitalized. They put her on antipsychotics and all this stuff, and then she stabilized. I think the one medication that stabilized her was, I believe it was Rexulti, yeah. But she would say that she would have these dreams, or she would wake up, and from sleep she would smell, like, you know how she used to live with her grandmother, pancakes being made, the cupboards are open, plates are out, and it would be happening in real time based upon her perception of reality. So she had been put on all types of antipsychotics. Nothing worked until she got on Rexulti. She was stable on Rexulti for a long time.
Mm-hmm.
Then there came these symptoms where when she would get really, really excited, would not sleep, confusion, symptoms like that. And then she got a diagnosis of bipolar. When
Mm-hmm.
she started seeing me, she said to me that she didn't think that she had bipolar disorder and gave me her reasons why. But then this thing would happen where she would be completely fine. And then as soon as she experienced some kind of stress, she would go into this state of paranoia, saying that somebody's trying to hack her computer and that somebody at work was trying to get her. And then as soon as that stressor resolved, the symptoms would disappear. And it was a constant, kind of like she was having like the brief psychotic disorder.
Yeah.
But it was coupled with some other things that was just so odd. I swear I just couldn't figure her out.
So what did you end up doing?
So I put her back on Rexulti, right? But the thing is, she'd be fine for months at a time. She'd be fine on months at a time. And then something weird would happen at work, and then all the symptoms would come back. So I put her on Rexulti, but then came the issue. She had a reaction where her hands were kind of like flaking. So long story short, she came for a while and then she didn't come anymore. So I don't know.
What happened?
That was the most odd thing. I mean, till this day, I think about her.
Mm.
As soon as she was stressed out, she would be so confused. I remember this one time, somehow her neighbor found my information and called me. And the only time she would calm down when she heard my voice, but she would just keep repeating these lines over and over and over again. And she was so confused and out of it. And then for whatever reason, I guess, okay, the job did the investigation and found that, okay, nothing happened. Her firewall is fine. Then the symptoms just disappeared. And it would be a constant battle and push and pull of these symptoms coming. She's fine for 4 months, fine for 6 months. Boom. They would come back when she's under stress. Her husband would go away for work. Boom, the symptoms would come back. Just very odd.
And was she still on the Rexulti those times? Is she consistently taking it?
She was. I tried to put her on some other stuff because of the kind of reaction she was having, the skin reaction she was having to the Rexulti, but nothing else quite worked. And she would not sleep. And the sleep, I think, was making things significantly worse.
That's hard.
Yeah, that was one of the most interesting things that I have seen. I'm just like, wow, okay.
Is it, I feel like I know, there's this lady I knew that would always get seizure type reactions when she got stressed. Conversion disorder.
Mm-hmm. Yep.
Every time she got stressed and ended up in the hospital just because, something was tugging at her. Tugging at her, and she would just have these seizures that, of course, EEGs, nothing like that could find.
The neurologic functional disorder related to that.
Yeah. So I don't know. That's interesting.
Yep.
Well.
Yeah, I have a patient too with somatic symptom disorder. She would swear that her blood sugar is low. She would have symptoms of hypoglycemia. She would have symptoms of hypotension, blood pressure, completely fine. Blood sugar, completely fine. She's gone to even like functional medicine. They've done all kinds of tests medically, and nothing can seem to explain why she's having these somatic symptoms, like the lightheadedness, feeling like she's gonna pass out, all that.
Hmm.
Yeah.
Well,
We have a lot of interesting
And
people.
yes.
Mhm.
Well, we got a lot of cases to talk about and for me to present. So I'll take some of these cases that y'all present and try to do some more case reviews. We may have to do these maybe twice a month because there's so much material out here. But if anything, these are taped. So if you can't make all of them, they'll be taped, and we're going to put them on YouTube, and we're going to label them so you can go in your leisure time and listen to what everybody else thinks about these different cases and get some feedback. Okay. Well, I'm going to go ahead and end it. And thanks for joining. And we'll let you know when the next one we'll probably do an additional one this month because I did one last month and basically I did the same case, but the taping mechanism wasn't working. But I have figured it out, and we're gonna put this on YouTube for everybody else, and we'll do another one later on this month, and I'll let you know the date. Okay.
Okay.
All
All
right.
right. Thank you.
Yeah.
Yes. Yeah. Thanks for
Thank
joining and
you.
participating. All right. Bye bye.
Thanks.
Thank
Bye.
you.
Bye-bye.
Bye bye.